Good day, class. This is Complex Nursing. My name is Alex McCartney Wallace, and my group members are Nishka Devilis and Dwanique Allen. And our topic on today would be acute upper gastrointestinal hemorrhage. We will now proceed to our diagnosis, which will be explained by Ms. Anishka Devilis.
So our diagnosis is upper GI bleed, and I will be speaking on the definition and pathophysiology. So for upper GI bleed, it's basically a life-threatening medical condition, and it's normally caused by lesions such as ulcers or erosions. Oftentimes, it could be due to peptic ulcers or stress ulcers in the GI tract, which result in bleeding of the proximal to the ligament of Treitz that can be classified as non-visceral or visceral. And visceral bleeding is when the pressure in the portal venous system gets too high, and is normally called the portal hypertension. And the ranges of that is anything greater than 5 to 10 millimeters per mercury is portal hypertension. So we know that for the portal vein, it carries blood from the digestive organ to the liver. So with that being said, with clinical manifestation, we have tachycardia, hypotension, corpus hematemesis, and our risk factors includes alcoholism and cirrhosis is what we see in our patient. So other risk factors includes age. Any persons older than 60 or 80 are increased risk of upper GI bleed. We have peptic ulcers and increased pylori infections, NSAIDs. All three of those irritate the mucosal layer of the GI and causes ulceration and erosions. So we have for stress-related mucosals, they normally also causes mucosal damage in the GI, ranging from small lesions to multiple gastric ulcerations that eventually leads to major bleeding. And oftentimes we see stress ulcers in patients with severe burns, trauma, or who have had major surgeries. So for the esophagus, we have the esophageal varices, epigastritis, gastritis bleed, gastritis, and chronic esophagitis, which is caused by GERD, smoking, alcohol, ingestion, or drug, often also irritates the mucosa. And also with esophageal varices, they occur from cirrhosis of the liver. So with the types of GI bleed, we have hematemesis. This is a bloody vomit. Apparent has fresh, bright red or coffee ground appearance, dark grimy digestive blood. And we have melena. This is the dark tarry stool, often foul smelling, caused by digestion blood in the GI tract. And the black apparent often is the presence of iron. And occlude bleeding, however, we notice that there's a small amount of blood in the secretions and in the stool. However, it's not detectable by the eye. So normally a GUAC test would normally be used to detect fecal occlude blood. And this is basically where the stool sample is placed on a GUAC paper, and then a hydrogen peroxide is added. And in the presence of blood, a blue reaction is produced within the stool. So we have severity of the bleeding. So with severity, we know that arterial bleeding often leads to like bright red, blood that is bright red, that is not mixed with gastric acid secretion. Capillary bleeding could be like slow oozing blood, whereas venous blood normally is dark colored. Tony?
I'm going to talk about our patient when we received him from the ER. So we received a male patient at around 10 p.m. He is 44 years old with a past medical history of cirrhosis and chronic alcoholism. On his way, it is noted that the patient had copious hematemesis, and the kidney basin on the side of him is filled with 700 milliliters of blood, which is approximately 70 gauzes. It is stated that he has been vomiting for the past 3 days, which started out dark and progressed to a bright red color. During the assessment, he complains of moderate chest pain to mid-proximal area and feelings of nausea. The patient then requests beer to drink. He is tossing in bed, he is diaphoretic, and his vital signs are 98.7 degrees Fahrenheit, 26 breaths per minute respiration, a blood pressure of 85/50, an oxygen saturation of 94%, and a heart rate of 144 beats per minute. His glucose is 88 milligrams per deciliter, and his Glasgow Coma scale is 12. He then has another episode of copious hematemesis, and immediately he is administered 4 liters of oxygen, 36% via a nasal cannula. He is placed on a cardiac monitor, his labs are obtained, and a PICC line is inserted to his right brachial, infusing normal saline at 50 cc's per hour. Here we have the patient's biographical data. However, what stands out is that he is a male and he has a past medical history of cirrhosis and chronic alcoholism.
So now we will talk about the ICU assessment and information. So he was transferred to ICU from the ER at 10 p.m. and he stayed approximately 10 hours. So when he was admitted to the ICU, he was administered oxygen at 4 liters via nasal cannula. He is on the cardiac monitor, and his PICC line is inserted. On initial assessment, his labs are obtained, and there's administration of crystalloids solution. He has an estimated blood loss of 30%, which is a class 2, and his first set of vital signs were obtained at 11 p.m., reading temperature of 98.3 degrees Fahrenheit, his pulse of 113 beats per minute, respirations of 22 breaths per minute, his blood pressure is 98/58, his glucose is 90 milligrams per deciliter, and his oxygen saturation is 94%. His labs are continuous and vital signs are initiated at every hour. Also, he has an indwelling urinary catheter inserted. His Glasgow Coma scale is measured, and it is confirmed that his clinical diagnosis are acute upper GI bleed secondary to esophagogastric varices. At 12 midnight, another set of vital signs were taken, and it shows that this patient is in the pre-stage of blood pressure, and his pulse is elevated, his temperature is decreased, and his respirations is also elevated. So the labs reads that his sodium is a decrease, his potassium is normal, his chloride is decreased, his bicarb is decreased. However, these signify that they are low, and it also signifies that the patient is in an acidotic state because of the continuous copious hematomatus. His creatinine and his glucose is high, and his liver enzymes. His ALT reads 56 units per liter. The AST is 43 units per liter, and the ALP is 55 units per liter. The ALP is normal, and it signifies that there's no liver or bone disease. But the AST and the ALT are elevated, showing that there is some kind of liver impairment. His alcohol level is elevated, as known. He is a chronic alcoholic. He has an anion gap of 47, showing that he is in a metabolic acidosis state. His PTT is 28 seconds, showing that the blood takes a longer time to clot, and his INR is 1. However, his WBCs are 13,000, indicating that there is infection, and his platelet is 111,000. The platelet is decreased, and his hemoglobin level and his hematocrit is normal. However, his GCS is 12, so it signifies that there's some mental impairment. His pH is 7.12, indicating that he is in an acidotic state. His partial pressure of oxygen is 75 millimeters of mercury, and his partial pressure of carbon dioxide is 49 millimeters of mercury, which is elevated. Now we'll move on to our treatment.
Okay, so for our treatment, we would want to do a nasogastric lavage. And what this does is that it confirms if the bleed is caused by upper or lower GI bleed. And we would want to and give normal saline 250 to 500 millimeters rapidly over 30 minutes. And then antibiotics prophylactic. Oftentimes with persons with upper GI bleed, it is often caused by a bacterial infection, which is could be precipitated by cirrhosis, which in turn causes visceral bleeding. So we want to give ciprofloxacin 200 milligrams IV twice a day. For proton pump inhibitors, what it does is that it inhibits gastric secretion of hydrochloric acid by the proton pump. It maintains high gastric pH, which inhibits clot formation and clot lysis. Okay, so our next treatment would be vasotherapy, vasoactive therapy. So what that does is that it causes flanking vasoconstriction, which decrease portal pressure and reduce visceral bleeding. And we want to give this upon admission before endoscopy and up to 5 days. So we would give for the vasoactive therapy would be telepressin 2 milligrams IVQ for hourly for the first 48 hours, and then we decrease that by 1 milligrams every 4 hours for the remaining 3 days. So we want to do an endoscopy, usually done 12 to 24 hours of admission, and we want to give erythromycin 3 milligrams kg over 20 to 30 minutes, approximately 30 to 90 minutes before endoscopy. And what that does is that it promotes gastric emptying before we do the endoscopy.
So now we go on to our interventions. For our patient, first intervention, you want to administration of crystalloids to achieve serum stability and increase blood pressure. Also, you want to monitor the portal hypertension continuously. Why? To detect elevated pressures in the portal venous system. You also want to do a continuous assessment of the pH gastric fluid to maintain prophylaxis, and also the continuous monitoring of the oxygen saturation to detect if the tissues are being perfused. Also, you want to put the patient in the Trendelenburg position to promote venous return to the heart and continue your vital signs monitoring for baseline data. And you want to irrigate the nasogastric tube with normal saline to control the bleeding. And then we'll move on to the rest of the interventions with Danique.
We'll also report abnormal Glasgow Coma Scale reading to the physician because a decreasing Glasgow Coma Scale indicates that the patient is deteriorating. We're going to provide comfort and emotional support to the patient. We're going to monitor surveillance and complications such as gastric perforation. We're also going to educate the patient and the family about gastrointestinal hemorrhage. We're going to teach the patient the importance of how to take the medication. We're going to encourage the patient to stop drinking alcohol because, as stated earlier, he is a chronic alcoholic. We're going to also encourage him to participate in several life changes, and we're going to refer him to an alcohol cessation program. So our end of shift report is as follows for the shift coming on. On handover at 8 a.m., Mr. John Doe was noted lying in semi-Fowler's position. Oxygen administration of 4 liters per minute, 36% via nasal cannula in no obvious respiratory distress. He is conscious and alert, oriented ×3. PIC line to right brachial infusing normal saline at 250 cc's rapidly over 30 minutes. His abdomen is round and tender. On auscultation of his lungs, no sounds of crackles were noted and bowel sounds are evident. No lesions, bruises, or wounds present. His vital signs were as follows. His temperature, 98.1 degrees Fahrenheit. His pulse, 95 beats per minute. His respiration, 18 breaths per minute. Blood pressure, 119/87. Oxygen saturation, 97%. Urinary output was measured, 200 milliliters. Bowels open. Glucose, 97 milligrams per deciliter. His EKG reads in normal sinus rhythm. His labs are continuous. Patient has had one episode of copious hematemesis and medications were administered. Terlipressin, esomeprazole, ciprofloxacin, and erythromycin. A patient also tolerated meds and no reactions were noted. Our patient was left in a comfortable position, no complaints, and continuous 1-hour vitals. Hygienic needs were met, safety measures ensured, patient condition is fair. Group 2.
Thank you for enjoying our presentation.